Welcome. You're at the cutting edge of cardiovascular sciences. I'm your host, John Cook. I'm professor and chair of the Department of Cardiovascular Sciences here at Houston Methodist. And with me in the studio tonight is Dr. Anahita Mojiri, who's an instructor in the Department of Cardiovascular Sciences and a budding star in age-related disease. And with us tonight is a pioneer in age-related disease, James Kirkland. He's the Nober Foundation Professor of Aging Research at Mayo Clinic. He's gone above and beyond duty by calling in from Dubai tonight, and it's 2 o'clock where he is, so thank you very much, Dr. Kirkland, for joining us on the show. But let me say a few more words about Dr. Kirkland. His laboratory was the first to publish the work on Senalytics. These are drugs, as you're going to hear, that can clear senescent cells from the circulation from the body and restore health, rejuvenate the animal or human. He published the first clinical trials of senolytic drugs. He has multiple clinical trials ongoing right now based on his preclinical work. He has more than 225 publications and holds over 20 patents. He's had numerous honors for his work. He was president of the American Federation for Aging Research and multiple other awards. He's a board-certified specialist in internal medicine and geriatrics and endocrinology, and is the 2020 recipient of the Irving S. Wright Award of Distinction from the American Federation for Aging Research. Dr. Kirkland, thank you so much for joining us on the show tonight.
Thanks, Dr. Cook. It's a pleasure to be here.
So you're in Dubai now. You're doing a lot of traveling with talking about the work that you've done. What have you learned in your travels recently in these age-related conferences that you've been going to that you're excited about?
Well, I think much of the world, especially research organizations and governments, are beginning to appreciate the potentially transformative impact we could have if we could target fundamental aging processes, as they appear to be root cause contributors for the bulk of conditions that cause most morbidity, mortality, and health expenditures across the lifespan. And of course, these processes begin at or before conception, occur throughout the lifespan, and can contribute to acute chronic diseases right through the lifespan, from babies to elderly individuals. And so I hope some of that will come across during our discussions today.
And so we're going to launch into your talk now on Senalytics. And maybe first for the audience, just tell us briefly what are Senalytics? This is a concept that you've propagated. Tell us a little bit about what a Senalytic is.
Okay, so first, by the way, I've got allergies, not COVID, if anyone's worried. First, maybe I'll talk a little bit about what senescence is, and then I'll get into what Senalytics are and how they were initially developed. So Senalytics, what they do is they target these cells called senescent cells. And senescence is a cell fate. It's much like cell division or cell specialization or differentiation, or programmed cell death or apoptosis. It's a cell fate. It can occur at any point during life. Cellular senescence can occur across the vertebrates, so from fish up, and can even happen in some invertebrates. And it appears to be generally a damage response that a cell can enter. So things like DNA damage can induce senescence, and that can be from repeated cell division. In fact, senescent cells were first discovered by Hayflick and Moorhead, or at least reported by Hayflick and Moorhead back in 1961, when they found that if they repeatedly replicated cells in culture, they stopped dividing, which is a characteristic of senescent cells, but they didn't die. And in fact, they were resistant to dying, and they got big and active. And these are also tend to be characteristics of senescent cells. So things like cancerous mutations and other things that occur in cancers can cause a cell to become senescent, including repeated replication. Things like reactive metabolites, reactive oxygen species, fatty acids, Even high glucose, 33 millimolar glucose, for example, can make cells become senescent. Mitogens are things that normally induce cells to divide, like insulin, or insulin-like growth factor 1 can induce a cell to become senescent through this replicative stress, repeated replication kind of stress. Proteotoxic stress can cause cells to become senescent. So protein aggregates, as occurs, for example, in Alzheimer's disease with aggregates of beta amyloid or tau proteins, can cause cells to become senescent, or in Parkinson's with alpha-synuclein, or in many diseases, including cardiac diseases with other kinds of amyloids. So external aggregated proteins can make a cell become senescent because they induce stress in cells. Mechanical stress can cause cells to become senescent. So this is the basis for senescent cell formation in the knee joint, but also in blood vessels where there are eddies and flows of blood. This can deform the nuclear envelope and through something called laminae induce senescence through shear stress. So this is partly why we see senescent cells forming on the venous side of arteriovenous fistulae that are fashioned for hemodialysis. And in fact, it looks like senescent cell formation is a major cause for failure of AV fistulae put in for renal dialysis. High oxygen or low oxygen can cause cells to become senescent. I'll come back to that. Inflammation can cause cells to become senescent, or indications from other cells that death is going on can cause adjacent cells to become senescent. And then pathogens can cause cells to become senescent, including coronavirus. The basis for a number of the clinical trials related to Senalytics and coronavirus currently underway. Now, it's very hard to define what a senescent cell is, the same way as it's hard to define what a differentiated cell is. There's no one particular signature from which you can say definitively with 100% certainty that a cell is senescent. So what we tend to do is look at aggregates of markers, some of which have varying sensitivity and selectivity, to determine if we would choose to call a cell senescent. Now, unlike other cell fates, it takes a long time for cells to become senescent. It can take from a week to 6 weeks, at least in culture. So it's a very slow cell fate to develop. A couple of the major pathways involved include P16 and P21, but either of these transcriptional regulators can be increased, both of them can be increased, or neither can be increased for a cell to be really a truly senescent cell. Most senescent cells develop something called a senescence-associated secretory phenotype, or SASP, I'll call it from now on. And this can entail production of a range of proteins and peptides, but not just proteins and peptides, but also bioreactive molecules, including bradykines, ceramides, and other things, and a lot of non-coding nucleotides, like mitochondrial DNA, various kinds of microRNAs, circular DNA, much like cancers produce. The SASP varies tremendously amongst senescent cells. It depends on the type of cell that became senescent, what drove the cell into senescence, how long it has been senescent, and its microenvironment. The SASP in about 30 to 70% of cases can be very tissue destructive, and it can evolve over time. So senescent cells are also defended against committing suicide, those that have a damaging SASP, because of what we call senescent cell anti-apoptotic pathways. And I'll come back to that because that's the basis for the discovery of Senalytics. So if you transplant even very small numbers of senescent cells in, say, autologous senescent cells, that is, you take cells from the ear of a mouse and you induce them to become senescent with radiation, because radiation, chemotherapy, and other things will make cells become senescent. And you put those now senescent cells back into the same mouse that they came from, but into the abdomen. And you can label the senescent cells you transplant so that you can distinguish the cells that are transplanted from the mouse's own cells. And what happens after a lag period, if you transplant enough senescent cells, is that the mice become frail, they have trouble running on a treadmill, their hanging endurance has decreased, their grip strength has decreased, and also after a lag period of several months, they start dying early. Whereas mice transplanted with also autologous ear fibroblasts, but that have not been not been radiated and therefore are not senescent, don't have this develop. And these mice that are transplanted with senescent cells die of every disease that naturally aging mice die of later on. So senescence is, like other fundamental aging processes, a root causal contributor to multiple conditions that cause morbidity and mortality. And it's interesting that there's a threshold burden of senescent cells that you have to transplant. If you transplant 1 million senescent cells into these middle-aged mice, they get this accelerated aging syndrome, and they get spread of senescence. But if you transplant 500,000 senescent cells, nothing occurs. And part of the reason for this is that senescence can spread from cell to cell, both in a local and a systemic manner. So you start finding senescent cells in the mouse's own arms and legs that are derived from non-transplanted cells. So senescence can spread. And our view is that if the rate of spread of senescence exceeds the ability of the immune system to clear senescent cells, which is how they're normally cleared, they don't die on their own, then you can get a takeoff and you can get this increase in senescent cell burden. So very small numbers of senescent cells in a middle-aged mouse, such that only 1 in 10,000 cells in that mouse, if it's senescent, can be sufficient to drive accelerated appearance of multiple age-related conditions. And we worked with the transplant group actually at the Brigham, Stefan Tullius, and we did heart transplants, or at least he did, from old mice to young mice and young mice to young mice. The hearts from the old mice contained senescent cells. The hearts from the young mice that were transplanted into other young mice did not. And what we found is that much like these experiments I just talked to you about with autologous ear fibroblasts, that senescent cells coming from the heart, in the heart of the old mice, induced the mouse's own cells to start becoming senescent in the recipient's mouse's liver. And these weren't the transplanted senescent cells migrating. These were those senescent cells in the heart causing the cells in the recipient's liver to start becoming senescent. And this is largely through these non-coding nucleotides, especially mitochondrial DNA, that senescent cells can release. We also found that the transplanted hearts from the old animals cause dendritic cells in draining lymph nodes, which are important for graft versus host disease to occur, to start becoming active. And we found that when we transplanted hearts from old mice to young mice, we got earlier transplant rejection than if we transplanted hearts from young mice to young mice. So all of these things led us back a number of years ago, principally driven by an important paper published by Ned Sharpless, who just stepped down as director of the National Cancer Institute back in 2004. He showed in Journal of Clinical Investigation that senescent cells, even though they're killing the cells around them, at least the 30 to 70% that are tissue damaging, survive despite the fact they're killing cells around them. And that led us to wonder, is that because these cells have pathways that defend themselves against the things they're using to kill the cells around them, much like what happens with certain kinds of leukemias and lymphomas? So we used a hypothesis-driven approach and bioinformatics methods to ask, are those senescent cells that are killing cells around them resistant to dying because they have defense networks that prevent them from committing suicide? And we found indeed they do. There are at least 5 of these. We found 5 of these networks. Now we know there are pathways. Now we know that there are 10 of them. They're interconnected in a network that we call the SCAP network that confers resistance to programmed cell death to senescent cells that are producing damaging factors. We identified key nodes on this network, and we use RNA interference approaches to test whether, if we knocked out parts of these defense pathways, that 30 to 70% of senescent cells that are producing damaging factors would in fact commit suicide. And we found that occurred. And we found that different human senescent cell types depend on different parts of this SCAP network to defend themselves from the things they're using to harm cells around them. So human fat cell progenitors, or preadipocytes, or some people call them MSCs, use one set of SCAP network pathways to defend themselves, whereas human endothelial cells use a different set. And each different cell type depends on different elements within this SCAP network to defend themselves from pro-apoptotic factors. So preadipocytes depend on, and other mesenchymal cell types depend on pathways that are related to something called Src kinase. I won't go into detail about it. Whereas endothelial cells depend largely on things related to BCL2, especially something called BCL extra large, which is the target of some treatments that are used for treating lymphomas. So what we did was we used early programs at the Broad Institute in Boston to try to find drugs or natural products that would target the same nodes that we found senescent cells depended on using these RNA interference approaches. We came up with a list of 39 compounds. All of them turned out to be senolytic in one or another human cell type. The ones we focused on early were ones that have short elimination half-lives, and I'll come back to the reason for that in a moment, and that have been approved for human use or are natural products with at least some kind of a record of a safety profile. And we also favored agents that were orally active, so we wouldn't have to inject them. A couple of the compounds we worked with early on are an agent called dasatinib. Now, it inhibits that Src kinase that I talked about before. It's a general tyrosine kinase inhibitor, but unlike other tyrosine kinase inhibitors, like imatinib, it targets this particular Src kinase that dependence receptors confer resistance to death in human mesenchymal senescent cells. We predicted it would kill the 30 to 70% of human preadipocytes, or MSCs, that are senescent and producing damaging factors. We predicted it would not kill human endothelial cells, and that turned out to be the case. We focused early on another compound called quercetin. It's a natural product. It's what makes apple peels taste bitter. It targets some heat shock proteins and some other pathways that human senescent endothelial cells depend on for their survival if they're producing pro-apoptotic factors. And indeed, quercetin at concentrations we knew we could get to in the blood of people was senolytic against the endothelial cells, but not preadipocytes, again, as we predicted. By the way, fisetin, another agent I'll talk about, is very closely related to quercetin. It's one hydroxyl group different. It's got a much shorter elimination half-life, and it's a flavonoid which is found in strawberries, where quercetin is found in apples. We combined dasatinib, which targets human senescent mesenchymal cells, and quercetin, which targets the endothelial cells, and we found that we could kill both cell types with that combination. And then Paul Robbins, working later on with us, found that there are some human senescent cell types that are tissue damaging that are killed by neither dasatinib alone nor quercetin alone, but are killed by the combination. And this is because some of these pathways that defend senescent cells against killing themselves can be redundant. So sometimes you have to hit more than one of them. So using that original hypothesis-driven approach, around 40 or 50 additional senolytics have been found. And since then, other ways of killing senescent cells or other ways of discovering senolytics have been found, including random high throughput screens that many companies are engaged with at the moment have yielded senolytics. One of the latest senolytics we developed with a group in China based on the original mechanism-based approach is procyanidin C1. It's in grapeseed extract, and it looks very promising. Other compounds that we developed and other groups founded around the same time are navitoclax, or ABT263. It has to be injected. It's a fairly toxic agent, and it targets BCL extra large, which I showed you before we found senescent human endothelial cells depend on. So the agents in clinical trials at the moment are mainly dasatinib, quercetin, fisetin, and navitoclax, although clinical trials are beginning with other agents. And since then, also some vaccines have been developed and other ways of killing senescent cells. Now, you don't always want to kill all senescent cells. Senescence can occur at any point during life, from preconception on. Down syndrome turns out to be a senescent-driven disorder, and that begins before conception with aging of the egg cell in the mother. But senescent cells can have advantages. They can help to clear away damaged tissue. They can help to prevent cancers from occurring, because cancerous mutations can drive a cell into senescence, and those senescent cells kill the potentially cancerous cells around them. Senescent cells also form in the placenta, and late during pregnancy actually drive the baby through the birth canal. So there can be beneficial effects of senescent cells, and you don't want to stop an individual from being able to make them. But what you do want to be able to do is get rid of tissue damaging senescent cells after they've been there for a while, outlive their usefulness, and especially if the immune system is having trouble clearing them. In other words, if there's a high abundance of senescent cells. So if you transplant senescent cells from the ears of mice that have been radiated and labeled so that we can see them with a light signal into the peritoneum of mice, into their abdominal cavity, and you administer a single dose of oral dasatinib and quercetin. Dasatinib in mice and humans has a half-life of about 3 hours, quercetin 11 hours. You eliminate that 30 to 70% of senescent cells that are tissue damaging. You leave the senescent cells that are important for wound healing and so forth, that are not producing tissue damaging factors, alone. You don't kill labeled non-senescent cells. If you take fat tissue from obese, younger, diabetic human subjects and put that tissue into culture dishes, you can keep that tissue alive for well over 72 hours. Senescence is a feature of diabetes and obesity, and especially when it's associated with inflammation and cardiovascular dysfunction and renal dysfunction. So you see a lot of senescent cells in this fat tissue. We can actually add Senalytics to human fat tissue in these explants and watch the cells dying. It takes about a 2-hour exposure to Senalytics to initiate a process of death in senescent cells. It takes 18 hours to complete. So Senalytics act very quickly. It takes a week to 6 weeks for new senescent cells to form. And that's why we decided to use what we call a hit and run approach to kill senescent cells. We're not trying for constant blood levels. And indeed, in the clinical trials, the FDA did not require us to look at constant blood levels. In fact, they didn't even require us to do a lot of pharmacokinetic testing. What we're doing is much more like what you do if you're developing an antibiotic. We're after a cell type. We're not after a single molecular target. And we're after multiple conditions that can be caused by that cell type. The same way as with the urinary tract infection, you might combine 2, 3, or 4 antibiotics to kill a particular kind of bacterium. You're not too concerned about what the molecular target is. You're concerned about killing that bacterium. And if you kill that bacterium, you may not only solve urinary tract infections, you might solve endocarditis, meningitis, skin boils, and all kinds of other conditions that can be caused by that bacterium. And you can use a hit and run approach. Often with urinary tract infections, nowadays you might give a single dose of antibiotics. So developing Senalytics is much more like that than the traditional one drug, one target, one disease approach that we would use for developing an antihypertensive, for example. So the way of thinking about the clinical trials has to be radically different than we're used to outside the antibiotic world. So with these Senalytics with respect to cardiovascular function, we worked with Jordan Miller at Mayo, and we found a number of things in old mice that we were able to improve ejection fraction in old mice with brief courses of Senalytics. We found we were able to reduce senescent cell abundance in the heart tissue. We could reduce calcification, and we were able to improve vascular relaxation in older mice in response to acetylcholine or nitroprusside. We also found, at least Jordan did, in ApoE deficient mice. Now, as you're all aware, there are no really good models of atherosclerosis in mice. There are better ones now than the ApoE mouse, but we did find reduced intimal calcification in these animals. What we don't know is whether we get issues with respect to cap stability or not, and that could be a problem. I might come back to that later. but we do find that we reduce intimal calcification, at least in some models. And Gina Ellison at King's College in London, working with us, found that in old mice, either genetically clearing senescent cells, I won't go into how we do that, or using the combination of dasatinib and quercetin intermittently, because we're using this hit and run approach. We're giving 3 days of drugs, 12 days off, 3 days of drugs, 12 days off for 4 cycles, that she was actually able to get some new cardiomyocyte formation, small cardiomyocytes, a particular population. And she was able to show with ethidium bromide and other approaches that these were indeed new cells. So we're able to actually, in old mice, which has been difficult to achieve before, get some new cardiomyocyte formation. Those mice that I talked about before, where we transplanted hearts from old mice to young mice and young mice to young mice, if we transplanted hearts from old mice to young mice, the young recipient mice died fairly quickly of transplant rejection and failure, whereas mice transplanted with hearts from young mice did fairly well. And we found that if we treated with senolytic agents, either the donor of the heart itself, or the recipient, we were able to improve graft survival and survival of the recipient. So I don't have time to go through them all, but there are at least 70 conditions now in preclinical models in mouse, rat, monkey, and other kinds of models, where we find that we can delay, prevent, or alleviate conditions across the lifespan that are related to the action of fundamental aging processes with senolytics. And you'd expect this if the geroscience hypothesis is true, and that's the geroscience hypothesis holds that fundamental aging processes appear to be root cause contributors of multiple conditions. But what we don't know is whether these agents will be safe and effective in humans. So we formed a network called the Translational Geroscience Network that's funded by the National Institutes of Health. University of Texas is amongst the members, at least elements of the University of Texas, and includes currently Mayo, Harvard, Hopkins, Universities of Minnesota, Michigan, Connecticut, Wake Forest, as well as University of Texas. And new members include St. Jude, City of Hope, the Stedman Clinic, Northwestern, University of Southern Illinois, and we keep growing. And what we're trying to do is multiple clinical trials of not just senolytics, but also what we call senomorphics. So senomorphics are agents that inhibit the damaging secretory, or at least I should say, components of the damaging secretory phenotype of senescent cells. So a senomorphic you may have heard of is metformin. So it inhibits aspects of the secretory state of senescent cells by targeting complex 4 in mitochondria. And another one is rapamycin, which inhibits parts of the protein and peptide components of the secretory phenotype. And we're also looking at agents like NAD precursors, sirtuin agonists, CD38 inhibitors, anti-inflammatories, and a range of other drugs and lifestyle interventions as well that can target fundamental aging processes. And we're trying to compare some of these agents across multiple conditions across trials. So one of the early trials that was published was for a condition called idiopathic pulmonary fibrosis, which is a pretty well universally, unfortunately, fatal condition that appears to be related to senescent cell accumulation in the lungs. And it tends to occur in older humans. One of the prominent features of idiopathic pulmonary fibrosis is pronounced frailty. So these patients, even more than shortness of breath, have difficulty with muscle strength and mass, and they have problems with 6-minute walk distance, 4-minute gait speed, chair stands, and short physical performance battery. Now, I caution that this is a phase 1 open label trial. There's no placebo control group. There could be learning effects here. There are all kinds of problems with interpreting these studies. I would not take it to the bank. But what we did, for what it's worth, find in patients who got 9 doses of dasatinib and quercetin over a 3-week period, and when we measured these functional measures before the beginning of treatment and 5 days after the last dose, remembering that these drugs have a short elimination half-life and they're long gone by 5 days, we did get an indication that there are improvements in these physical function tests. And that's been sufficient to motivate us to begin to move on towards a phase 2A, a double-blind, placebo-controlled trial that'll be in multiple sites, including a site at University of Texas. Another early trial that was published in 2019 was what we call a target engagement trial. So we were looking here to see if, by giving oral dasatinib and quercetin in humans, we could eliminate senescent cells from adipose tissue of obese, younger, diabetic human subjects, much like the fat tissue that I talked about earlier. And so what we did was we did a biopsy in these subjects. They were kind enough to allow us to do a fat tissue biopsy at day 0. We did another fat tissue biopsy at day 14. And we gave 3 days of Senalytics on days 0, 1, and 2. This is oral dasatinib and quercetin. And we compared the biopsies at day 14, 11 days after the last dose, long after the drugs are gone, to day 0. And we found decreases in P16, which is a somewhat sensitive and specific marker of senescence. Senescence-associated beta-galactosidase, which is about 2/3 sensitive and specific. And we also found decreases in inflammation, which I don't show, in fibrosis. And then we work with David Allison he's dean at University of Indiana, to develop a composite score of factors produced by senescent cells that could be measured in the blood. And we found that this very short course of Senalytics was sufficient to reduce those circulating blood factors. So we're fairly convinced, but not entirely yet, that we've got at least target engagement, and we've got safety and tolerability data in humans, and we know the doses to give. At least we think we know the doses to give to decrease senescent cell burden. And we've confirmed this in some other kinds of studies later on, that this composite score seems to be all right. There are going to be better ones, and they're being developed. So currently there are around 30 trials underway. There are another 15 planned. 16 of the trials are with Senalytics at the moment. The other trials are either observational trials, what we call minimal risk trials, or they're trials with other agents. In some of the Senalytic trials, we're using the combination of dasatinib and quercetin. In others, we're using fisetin. There was a trial published by a company recently using navitoclax, or ABT263, injected into the eye of people with age-related macular degeneration that showed very promising results. But the trials underway are mainly phase 2A double-blind placebo-controlled trials at multiple sites throughout this translational neuroscience network. We're trying to measure the same things across the trials. So we're measuring about 150 things in blood, in urine, in saliva, epigenetics, and so forth across all these trials. And the trials range for conditions from childhood cancer survivors, which we're doing at with St. Jude. They found that people who've had chemotherapy or radiation before the age of 10 some of them are developing an accelerated aging-like state, and they're dying at age 35 or 40 of Alzheimer's disease, strokes, heart attacks, second cancers, and frailty. And we found the likelihood of their developing this accelerated aging-like state is very, very predictable by senescent cell abundance in skin biopsies. So the National Cancer Institute is funding a trial where we're comparing fisetin to dasatinib and quercetin in those people at St. Jude. We've got trials going on for frailty in elderly individuals with a low gait speed. We've got 3 trials for coronavirus. We know that viruses can induce senescence, and also senescent cells take up more coronavirus, 3 times more coronavirus than non-senescent cells. And senescent cells produce factors that make cells around them susceptible to coronavirus. Furthermore, it looks like senescent cells mutate viruses and could be a source of some of the variants that are occurring of coronavirus. So there are 3 trials underway for that. We don't know the results yet because these are double-blind placebo-controlled. There are 3 trials underway for Alzheimer's disease, a trial underway for mild cognitive impairment, several trials funded by the Navy, US Navy, for osteoarthritis. There are trials underway funded by the NIH for age-related osteoporosis. There are trials underway for bone marrow transplant survivors, and a range of other conditions. And there are interesting trials underway, or at least not with drugs, but to look at senescent cell accumulation with respect to space travel. because we know that astronauts have a lot of DNA damage when we look at their blood and urine when they return. We worked with Brookhaven National Labs and the Colorado Space Center and people actually at the University of Texas. And we found that very, very low doses of space radiation, that is hydrogen, helium, and selenium traveling at light speed, are sufficient to induce senescence, 40 times lower doses than X-rays or gamma rays. So we're studying at the moment the astronauts that were on the Axiom SpaceX mission that took off a few months ago, and they took our cells up as well and have been, they studied those. So we don't know the results of all of that yet. So this has gotten quite amazing. I'd caution, we don't know if any of these drugs really work in humans. So just by way of conclusion, it looks like persistent senescent cells can cause inflammation, fibrosis, progenitor cell dysfunction. I didn't have time to go into that, and spread of senescence. The target of Senalytics is senescent cells. It's not a single molecular pathway, so we favor using what we call dirty drugs or combinations of drugs, especially if we can give them orally and if they're relatively safe, and we can flatten side effect profiles by giving multiple agents instead of single agents. We find that Senalytics, at least in animal models, can attenuate tissue inflammation and fibrosis and improve function and reduce rejection after transplanting organs. It looks like a hit and run intermittent treatment approach may be effective. It looks like, at least in animal models, like other geroprotective drugs, like metformin or rapamycin or other agents, that we're able to delay or alleviate multiple chronic diseases, some acute diseases, improve tissue regeneration, and enhance health span. But this is in experimental animals. We don't know if these drugs work in humans yet. That's why we're doing these trials. That's why I'm working all hours of the day and night, and so are my colleagues, is to try to do these trials in parallel instead of in series. We know that the chance of a phase 2A clinical trial in humans working is about 5%. So I predict most of these trials will fail. And that's why we're trying to do multiple trials in parallel to see if we can test once and for all whether Senalytics are going to be amongst the potential answers within the gerotherapeutic armamentarium that I think we really, really need in every country around the world to test quickly to see if there's anything to this or not. But in the meantime, I don't think physicians should be prescribing these drugs. I don't think people should be taking them over the counter until we've done very carefully controlled clinical trials. In our case, they're all monitored by the FDA, and until we're sure that these drugs are safe, because anything that sounds too good to be true usually is. I'm sure there are going to be some downsides. I'm touching wood. We haven't seen serious adverse events yet and haven't had trials stopped by our data safety boards, but it doesn't mean that won't happen. So I'll just conclude by thanking an awful lot of people. Tamara Ciccone and Izu were instrumental we worked together to discover the first Senalytics, and there are multiple granting agencies who've helped us out on this journey. So thanks, and sorry for talking on, but even though it's the middle of the night for me, it gets me excited.
Dr. Kirkland, that was magnificent. What an amazing story. A conceptual framework change that's just dramatic. We're hearing about an entirely new way of thinking about aging, and you're really, you've led an amazing scientific effort all the way from molecule to man, and best of luck on those trials that you're doing. We're hoping that you're going to be successful. Before we start the discussion,
I just caution it's not about me. This is a lot of people. I'm just a bit player in this. It's a very huge team working on it, and I just hope some of it works out, and that's why we're all working day and night.
Mm-hmm. Well, it's amazing. Before we start on the discussion, let me just remind our viewers that you can get involved here. You can join by text, and the way to do that is text, you dial 37607 and text DeBakey. So text DeBakey to 37607, or you can go online to pollev.com, and enter DeBakey, and then you can ask questions. I guess if I could start, one question that I had was about how can I quantify the number of senescent cells in an individual? I'd like to know how many senescent cells I have, for example.
That's a very, very big question, and it's you're right on the mark. So there are extensive efforts around the world to develop what we call gerodiagnostics. I think the field has moved beyond looking for just biological, what we call biological clocks. The best biological clock I have is my birth certificate and my pocket calendar. So, knowing sort of how biologically old I am may be sort of interesting, but what we need is markers that meets the criteria that the FDA requires to get things to the point of being what we call an endpoint in a clinical trial. So we have to know that the biological marker or markers, I think they're going to be composite scores, reflect senescent cell burden in the body. We need to know that if we clear senescent cells genetically or with drugs, that those markers go down. We need to know that if those markers go down, that'll predict a response, a physical response to the agents, like an improvement in a condition. We need also to have markers that are reliable, sensitive, and specific. We need markers that hopefully could be easy to use in a physician's office one day and could guide the physician about which intervention to use. I mean, why would you use Senalytics, for example, if you have no senescent cells? Mm-hmm. So you might want to use some other gerotherapeutic if you have no senescent cells, if it's in a preventive mode earlier in life.
Beautiful. And just one
so
follow-up.
We love to have markers that tell us which drug to use. And so this is a tall order. The FDA has been working with the community on this. A number of big pharma, small biotech, and investigators around the world are working on this. And we've had conferences in Bethesda in the Washington area to try to come up with overall strategies for how to push this forward and find out what the NIH and FDA would want. And I think what will be important is, and some of the big drug companies have actually said this, they've got some of their own proprietary tools. Some of them have said they'll give that up for $1 if we could create an agreed on series of, or a composite score or whatever, of markers that we could use, much like a highway is publicly funded, and then companies drive their own trucks down it.
Right. That's brilliant. And just one follow-up question. You mentioned the concept of focal senescence, that areas of the body can age more quickly than other areas of the body. And some individuals may, their heart may be aging faster than some other organ. What about organ-specific aging? How do we measure that?
Well, one of the things with senescence is it spreads, unfortunately. And so we're beginning to doubt whether there really is completely organ-specific senescence, because wherever we've looked so far, if we've found there's a burden of senescent cells in one organ, there's at least some increase elsewhere in the body. Mm-hmm. For example, if you find an increase in senescent cells in the knee joint, we've got some early evidence that we're working on with collaborators, especially at Johns Hopkins, that there may be increased senescent cell burden in the spinal fluid.
Wow.
So, we don't know how much can be local, how much is systemic. It's sort of like with scleroderma. Scleroderma is a condition that is related to cellular senescence. These myoepithelial cells in scleroderma. And scleroderma can be focal, or it can be systemic. And often it goes from being focal to systemic. And people with scleroderma, they start off with a disorder in their skin, but they often die of catastrophic renal failure or heart failure because of fibrosis spreading. And so with senescence, I think if you get above a burden of senescent cells to the point where their formation exceeds the ability of the innate immune system, it's normally natural killer cells that kill senescent cells, to remove them, you may get this takeoff, and it may be body-wide. And this may be why, along with other fundamental aging processes, we find this multimorbidity state in older individuals, where if older individuals get one healthcare condition, the second one isn't far away, and the third one, if they've got two, is even closer. So you find that health conditions tend to increase in number in an exponential manner in older individuals or individuals who, say, have had chemotherapy or radiation or some severe infection or other things that can induce senescence or genetic disorders.
We've got some questions coming in from the audience, but I think I'm going to turn to my junior colleague, Dr. Mojiri. She has some questions for you as well, and then we'll go to the audience.
Sure. It was a wonderful talk. Thank you very much for sharing those data. Actually, I have many questions, but let's start with what did you see as a general side effect of using this senolytic?
We're not sure what general side effects are yet in humans. I'm sure there will be. There are certainly drug-specific, agent-specific side effects. So dasatinib is, it's not a terribly dangerous drug, but it's not the safest drug in the world. It's been on the formulary since 2006. It's just coming, or in some countries it's off patent. It's used for treating leukemias and lymphomas. It's given daily to do that. Side effects can occur after a couple of months, particularly involving hematologic side effects and others. But one thing, by giving these agents intermittently and giving them once a month or once every 2 weeks, we can reduce side effects because it has a short elimination half-life. So it doesn't have the time to do that it can do in people who have leukemias or lymphomas who are taking it daily for years on end. Dasatinib, for example, has another drug-specific side effect. It can prolong QT intervals. So we have to not take patients with QTCs that are prolonged onto the trials with dasatinib, whereas other senolytics don't necessarily do that. So each agent has its own series of side effects. Fizetin, which is a natural product, as I mentioned, it's in strawberries, but we have to give it at a dose where you would have to eat 15 pounds of strawberries within 5 minutes to get the dose that we're giving. At that kind of dose, there can be a bit of GI upset and some other things. That tends to be the main thing we've seen, but the way we do it is we actually mix it in chocolate pudding, and people seem to like that. But every agent will have its side effects. There's no such thing as an agent that doesn't. And they tend to, so far the side effects that we see are agent specific, but it doesn't mean that we won't see general side effects of senolytics as a class. And that's one of the things that we're looking for. I would certainly not want to give senolytics to a woman who's pregnant, because I could see problems with fetal development and remodeling. And also, as I mentioned, senescent cells are important in the placenta because they drive the baby through the birth canal. They produce the factors in the last 5 days of pregnancy that do so. So there are a number of conditions or states where we would not want to see, would not feel it advisable to use senolytics. We've got a long list of exclusion criteria in the trials just because we don't know what the problems can be. And we're also only studying people with very serious illnesses for which there are no good treatment options and where we know that there's an increase in senescent cell burden in the first place. If we find they're safe and effective there, then we may march backwards more and more into a preventive mode. But at the moment, we're in a treatment mode.
On that point, we have quite a few questions coming in right now, and several of the questions are about the point that you've made that the senescence can spread, and someone compared it to a malignancy here, and the question is asking if it's like a malignancy. What are the mechanisms? You did mention a little bit about the mechanisms of this senescence spreading. Tell us a little bit more about how senescence spreads throughout the body.
We don't know all the mechanisms. We know a number of inflammatory mediators that senescent cells produce can do this. They produce exosomes and other extracellular vesicles that contain factors that appear to be able to spread senescence. And they're producing various non-coding nucleotides that appear to be able to do this. So we don't know all of the mechanisms. Also, in individuals with senescent cells in one part of the body, they may have what we call pre-senescent cells in other parts of the body that are just poised to become senescent, where those cells have undergone repeated replication as it is, and they might just be on the verge, and it might not take much to push them over. So we don't know all the ways that this can happen. It looks like some kinds of immune cells which circulate can become senescent. So they could arguably deposit in different parts of the body as well. So there are multiple ways that this potentially might occur.
Another question that came up was about environmental causes of senescence, and one question is about climate change. And are there any studies of climate change in senescence, or maybe different rates of senescence in different geographic areas?
There are certainly different rates of senescence in different geographic areas. How much of that is related to sun exposure, to water quality, food quality, genetic issues, and all kinds of other environmental issues. We don't really know completely at this point, but it looks like a lot of stressors can induce cells to become senescent or maybe involved in the process. It appears that some organisms that live at the poles have very delayed senescent cell accumulation. There's not much really known about that. There appears also to be a link between senescent cell burden and the maximum health span and lifespan of a species, but again, that's not perfectly understood. The habitat of a species can very much be related to the rate at which fundamental aging processes occur. So species that are generally protected against predation, like the Greenland whale, for example, and live in Arctic areas, can live to be hundreds of years old. And we don't know with Greenland whales, but we do know with other species that are like that and have greatly increased health span and lifespan compared to other species, that there's very delayed accumulation of senescent cells. But they're able to produce senescent cells when they need them. If they didn't, they'd die of cancer.
If we can ask about one of the clinical trials you mentioned about pulmonary fibrosis, you mentioned that the physical function improved significantly, which is great. How about the pulmonary function? Is there any evidence that basically you have healthier cells, that's why they are doing better?
That we don't know in humans, and that'll be one of the things to look at in a longer clinical trial. I'd emphasize this was a very short clinical trial that was done. It was not placebo-controlled. It is clear in mouse studies that we collaborated on with others at Mayo, including Marissa Schaefer and Nathan Nebraska and others, using a model of, an imperfect model though, of pulmonary fibrosis. It's induced by mice inhaling a drug called bleomycin, which induces senescence. In that particular study, there was improvement in lung function in a mouse model, but it doesn't mean it'll occur in humans. You know, we need to test that prospectively.
And if I can ask one more question, because I work on the progeria disease, and as I'm sure you know, it is a premature aging that basically all the cells that express lamin A are senescent, and then neighboring cells. Have you tried that senolytic on the progeria mice?
Yeah, there are a number of studies in Hutchinson-Gilford progeria models. There are at least two different models that have been looked at. The results are slightly different in each model, and the nature of the Senalytics that appears to work is a bit different in the two models, but it does look, at least, and I'm touching wood, that there's some promise there. There hasn't been a move yet to looking at this in people with Hutchinson-Gilford. I think there needs to be more in the way of basic science data to do this. And another area, prodroid syndrome that's being looked at fairly actively, and I don't know how long it'll take to get to clinical trials, is adult Down syndrome. And this was based on work that came out of MIT earlier this year in human neurospheres. It looks like in Down syndrome that the trisomy 21 is associated with changes in the way that chromosomes are bound to the nuclear wall, including, which involves lamin A, and how chromosomes touch each other. And it turns out that in neurospheres, little sort of mini brains in culture from Down syndrome patients, that this group at MIT was able to restore neurogenesis by treating with dasatinib and quercetin those neurospheres. Now, it's very, very, very early. There are only a couple of studies published so far. But I think adult Down syndrome might be another place where we would want to move towards looking if preclinical studies show that there's any promise there. But we're a long way from that.
Another question from the audience is how much lifespan or health span do you think you can give us with Senalytics?
Well, frankly, as a geriatrician, I've never had a patient say to me they want to live longer. And there have been some informal polls done by AARP, and a lot, especially of older people, don't necessarily want to live longer. They want to feel better and feel healthier. So what we're really concerned about at this point is health span. And because we're early in this process, we're looking at diseases and serious disorders that we know are linked to fundamental aging processes. One day we might get to lifespan. There's a lot of controversy about senescence and lifespan, and it depends very much on if you're looking at animal models, which animal model you use. If you're looking at Senalytics, depends which agent you use. But frankly, as a practicing physician and watching people die in front of me, including with certain cancers that I think we're going to want to target with these agents, my priority right now is the patients that we have in front of us.
That's a great answer. Go ahead.
I was actually, you mentioned that we have a good senescent and bad senescent cells. So is the senolytic drug could differentiate that? How we control killing one group but not a good group of cells in the body?
Well, it's something we're working on. Tamara Ciccone and myself, Utkarsh Tripathi in our lab, and others are currently looking at that. Sorry. So it's a bit early to say, but just suffice it to say that Senalytics act by killing those senescent cells that are producing factors that kill cells around them. That's how they work. So they kill a different subset of senescent cells than, say, from Incotac mice or other mouse models, where you can selectively kill cells that have high P16 or high P21. And the effects that we're seeing of Senalytics are quite distinct from the animal models. And different Senalytics appear to have different effects. So at the very least, with most, with Senalytics, there are senescent cells that are killed and cells that aren't. And we're currently characterizing both of those populations. But suffice it to say that the cells that senescent cells kill are the ones that produce factors that damage cells around them. They leave the ones alone that don't, or have lower levels of those factors.
Well, Dr. Kirkland, I'm going to ask one more question I think most of the audience wants to know, and that is, what is Dr. James Kirkland doing to extend a healthy lifespan? For
that
yourself.
Will remain a secret for a long time.
Okay, good
And
enough.
if there's anything that's being done.
That's fair enough. Well, I want to thank you so much. You went above and beyond to give us a wonderful lecture, calling in from Dubai. I guess it's nearing 3 o'clock in the morning there.
2 minutes short.
I really appreciate it. And I congratulate you on such a wonderful work you've done, and with giving us great hope and promise for great things to come. And we're wishing you the best in your clinical trials. And look forward to seeing you here in a few weeks in Houston.
Yeah, thank you very much. And I'd emphasize this is a large team. I'm only one member of the team. So there are literally dozens or hundreds of people now working on this.
That was Dr. James Kirkland calling in from Dubai. Dr. Kirkland is from Mayo Clinic, where he is pioneering this new field of senolytic therapy. Thank you very, very much, Dr. Kirkland, again, for joining us tonight.
Thank you.